Good evening, friends. Welcome to the session of Conceptual Spine Connect today, wherein we are going to discuss about osteology. So this is one topic wherein generally the candidates get scared whenever a vertebra is given to you and you are asked to talk about it. But you should know the basics so that that scare and fear is gone, because at the end of the day, you are the conceptual students. So you should have the confidence regarding this. So when we talk about embryology, all these vertebrae are made out of somites. How many somites are there? This is very much important. Four somites in the occipital, eight in the cervical, 12 in the thoracic, five in the lumbar and sacral, and there are 8 to 10 coccygeal somites. So this in total form all the vertebrae. Now the derivation is separate into the cranial and caudal portions. The sclerotomes are the precursors of the vertebral arch and the body, which reach in the midline, which surround the neural tube and the notochord. Overall, if we talk about the different parts from which and how exactly the spinal cord and the vertebrae around it is formed is from the sclerotomes and dermomyotomes. So the number of somites is very much important. There are four in occipital, eight in cervical, 12 in thoracic, five each in lumbar and sacral, and 8 to 10 in coccygeal. Now, whenever we talk about the derivation of from the sclerotomes, how exactly the vertebral body is formed? So the lower part of the vertebrae and the upper part of the vertebrae, basically it is formed from two different somites. So one vertebrae, if you see over here, the inferior part of this vertebrae and the superior part of the vertebrae is formed from different somites. So basically one somite will form the proximal part of the vertebrae above and a part of the vertebrae below and the disc space in between. So basically, whenever we talk about the somites are such that the proximal and distal vertebrae, parts of those with the in-between disc space is formed from a single somite. The structure that is present in between is a notochord, which basically forms the nucleus pulposus, and the sclerotomes forms the part of the vertebral body which is around it. Now, this is a reason which is said to be that whenever we talk about infections, the disc space is involved. Along with that, the proximal and the distal vertebrae in parts, because this is how the infection happens, which goes back to the sclerotomes. The infection will basically affect a particular sclerotome, which will cause the disc space and the body above and below to get impacted. Now, there is a cranial neuropore, caudal neuropore, and in between, when it closes, it forms the neural tube. Early in the stages, there is only a brain fold and a neural groove which is present. Over time, as the development happens, the cranial neuropore and the caudal neuropore develop, and the neural tube in between which closes. So this in total forms the spinal cord overall, starting from all the way cervical spine and the occiput, lower down till the coccyx. If you see this microscopic structure, the notochord, the neural tube, the surface ectoderm, amniotic cavity, somites, the lateral plates, the endoterm, they differently form different parts of the spinal cord. Now, coming to the main discussion, which is the anatomy, because this particular embryology we are going to discuss in future as well before we wind up with our osteology. So now, one important thing about the nerves in cervical spine as compared to the nerves in the lumbar spine is how exactly they exit. Now, if you look at the lumbar spine, we have discussed this multiple times that at the level of L4, the L4 nerve root will exit from below the pedicle. However, that doesn't apply to cervical spine if you look closely over here. So it is a C5 nerve root that exits as compared to the same nerve root as corresponding to the vertebrae in the lumbar spine. So in cervical spine, it is +1 basically, and in lumbar spine, it is the same. Now, also this particular nerve root reaches at a right angle And this explains that foraminal and central herniations affect the same nerve root in cervical spine, and there is no discrepancy as what we see in the lumbar spine, wherein the foraminal and the central herniations generally affect different nerve roots. So to revise, basically when we talk about the central herniations in lumbar spine, that affects the traversing nerve root. However, foraminal herniations affect the exiting nerve root. As compared to that, when we talk about the cervical spine, be it the foraminal disc or the central disc, that will affect the same nerve root and it will not change. So over here you see, this is how the nerve root exits via the foramen. Just below the nerve root in the foramen is the vertebral artery. This is the uncinate process and this is the disc. So a central disc herniation over here is going to compress this nerve root, and the foraminal disc will also compress the same nerve root over here, because in cervical spine that is the same nerve root that exits. Now, this is the very reason why, my friends, in general in cervical spine, lateral mass screws are preferred over pedicle screws, because there are chances of injury to the vertebral artery which is there in the foramen. We are going to discuss this also in details. Now, the first bone of the body of the spine is atlas. So now atlas is basically consists of the anterior arch, the posterior arch. There is an anterior tubercle, there is a posterior tubercle. Transverse process is present. Along with that, there may be complete arcuate foramen that you see over here, which may be absent in some patients. This is the inferior articular facet, transverse process, and there would be a superior articular process as well. Now, in 3 to 15% of the population, the atlas may be absent or it may be fused with the occiput. The weakest point of the ring is at the narrowed areas where the anterior and the posterior arch meet each other and they are connected to the lateral mass. This is basically the location of the Jefferson's fracture, and the reason is because it is the weakest. The important thing is that they ask you how many tubercles are there in C1. There are two tubercles, the anterior and the posterior tubercle. Transverse process is present. Transverse foramen is also present. There is a facet which is present. There is a facet that is present for the dens, and there is an arcuate foramen. In some patients, the arcuate foramen may be incomplete, and some it may be absent. Now, in general, when we talk about the how much is the safe area for the vertebral artery and for the dissection for C1. So basically, we can only dissect up to 1.5 centimeters safely whenever we are doing a posterior surgery, because beyond this is the groove for the vertebral artery posteriorly. So this mark that you see over here is the groove for the vertebral artery. If ever you require an extra dissection, you may dissect the artery from the groove slowly. With this, the area of dissection can increase from 1.5 to 3.5 centimeters. So beyond 1.5 centimeters, it is not safe, and it is safe only if you dissect the vertebral artery as well. So this is important because this is asked. How much is the safe dissection in centimeters that you may do? That is 1.5 centimeters. Now, the second vertebrae is the axis. Axis is basically a characteristic vertebrae because of the presence of the odontoid process. Along with this, there is a superior articular process that you see over here, or the superior articular facet that articulates with the C1. Inferior articular facet that articulates with C3. A lamina that is present, and the spinous process. There is an anterior articular facet again for C1 of the dens, which articulates with this particular anterior tubercle right over here.